So I want to introduce Dr. Speer. He had his training at Baylor College of Medicine, and he has also served as president of multiple organizations, including the AAP Texas chapter and the Texas Medical Association. Um, uh, he has served as chair of AAP Executive Committee for the section of perinatal pediatrics and past member of AAP Committee on Fetus and Newborn. And then, of course, his work with NICU Advisory Council and the Collaborative.
Okay, if I'm looking at the clock correctly, I've got roughly 30 minutes, so it's hi-ho silver time. Before I start, though, I have just noticed a new phenomenon. If you do not have an aisle on the back, people congregate along the aisles on either side, but avoid the furthest corner at all costs. All right, so let's go forward. We can put it there if you want it. All right, this is neck. I don't know how many of you have been up close and personal with necrotizing enterocolitis, but you can see over here the pneumatosis cystoides intestinalis, which is air within the wall of the bowel. And when you operate, you can see all this dead tissue, very little there. So this is one of our major problems that we have in neonatology, is infection. The incidence changes as to where you are, and I'll show you a slide shortly looking at meningitis, but roughly 0.3 to 0.5 per thousand live births overall. Okay, so we're talking about relatively small numbers overall. Meningitis, 0.3, maybe 0.2. However, if you're small, you get sick a whole lot faster and a whole lot more frequently. So if you're 1,000 to 1,500 grams, 10% of you are going to get an infection. If you're less than 1,000 grams, 35%, and if you're less than 500, almost half. This is the slide so far as meningitis, and it reflects the milieu of hygiene, the ability to keep things clean, the use of contaminated water if you're making up artificial milk as opposed to breastfeeding. You can see the United States is down here, but there is a great swath of the world that has significantly higher rates of meningitis. If you take the very low birth weight all by themselves, earliest onset infection, less than 72 hours, is about 1.5 to 2%. If you're down to 22, 28 weeks gestation, which gets you into the extremely low birth weight, it rises, it almost doubles. Late onset infection is much more common, less than 25 weeks. You can see the number. If you're less than 1,500 grams birth weight, 20% will have 2 episodes of sepsis during the hospitalization. Mortality, it's variable. Depends on the organism, depends on when the baby's born, depends on how symptomatic the baby is at the time of birth. But as you can see, the average gram-negative rate of death is around a little higher than a third. The average gram-positive is closer to 10%. And if you're symptomatic and sick on day of life 1, the rate is about 50%, no matter what the organism may be. And about 50% of the neonatal deaths after 2 weeks of life are due to some form of infection. Again, if you look at autopsies, and this is where an autopsy is very valuable, is that there's evidence of viral, fungal, or bacterial infection frequently present at autopsy, and we didn't know it prior to the baby's death. Route of acquisition. This next 3 slides reflects the fact that I was a rotating intern. Does anybody know what a rotating intern was? She does, because she and I are sort of kinship here. It's where the intern went around to internal medicine, OB, surgery, pediatrics, and maybe an elective. Well, this is an OB elective, obviously. So prepartum, that reflects maternal infection. Rather rare, but if mom has bacteria in her bloodstream or has chronic intrauterine infection like listeriosis, the baby is going to be infected. Intrapartum is early onset infection, so that's maternal vaginal flora. Postpartum is hospital acquired, or used to be called nosocomial, or now it's a HAC, a hospital acquired condition. I'm not quite sure what hospital acquired conditions have to do with infection, but that's what they call them. These are the organisms that infect mother. These are the organisms that are in the vagina. And these are the organisms harbor in our NICUs. Virtually every NICU has its own favorite organism. It's the organism that infects most of the babies, and so one needs to tailor your initial antibiotic therapy for just that possibility. Why do babies get infected? Well, my question would be, why don't all of them get infected? Because they have diminished humoral antibodies. Remember that IgM and IgG do not cross the placenta ever. IgG crosses the placenta, but only after about the 32nd week of pregnancy. Babies don't have very many polymorphonuclear phagocytes, in other words, segmented cells, and they're not real smart in swallowing up their bacteria, and they're even stupider at trying to kill the bacteria, frequently because of the halide lack of systems and the lack of hydrogen peroxide generation. Complement, opsonins, lysoenzymes are all lacking in the baby's bloodstream, and they have specific enzyme production they can't do. For example, if you and I get infected with Staph aureus, we have the ability to produce anti-hyaluronidase. Hyaluronidase is produced by the Staphylococcus and lets them pass through tissue planes by destroying that protein matrix. You and I can wall off that organism, so we have staphylococcal abscesses. Babies have a very poor time at walling off the abscess, so the bloodstream may indeed be positive when you get the blood culture. This is an illustration of the postnatal IgG levels. As you can see, in yellow is term, orange or red, depending on your color blindness, and perhaps brown, are 29 to 32, and blue is 25 to 28. And you can see the lower gestational ages, from birth, they are essentially hypogammaglobulinemic. They do not have these enzymatic processes to help protect. The inflammatory process is illustrated here. I'm certainly not going to go through all of it, because I would get confused as you would. But what I'm trying to show you is there's a balance between pro-inflammatory and anti-inflammatory cytokines, and depending on how things work out, you may have uncontrolled inflammation, or you may have very little inflammation, as it is in the extremely low birth weight babies. They don't get fever. They look well 1 minute, and they look dead the next minute. They don't have any prodromal symptoms, as you and I might. And bacteria in the innate immune system, bacteria are smart. They produce all sorts of things to claim territory. In fact, they will actually produce systems like adenosine monophosphate to adenosine to fool the white cell into thinking it's a benign substance that's in the bloodstream, and others will produce symptoms that will coat themselves so another bacteria can't interfere with their growth. And you can see that these things are ongoing. Antibiotics, I think very important, and I'll talk about them much more relevant in a bit. Bactericidal antibiotics kill bacteria. Bacteriostatic antibiotics slow the growth of reproduction. So in newborns, because they can't kill bacteria, because they can't phagocytose, and they can't have diminished intracellular killing, they are much more at a disadvantage. So that's why we don't use bacteriostatic antibiotics in the newborn period. At least you shouldn't be using bacteriostatic antibiotics in the newborn period. Bactericidal inhibit cell wall synthesis, cell membrane function. They cause DNA fragmentation and protein synthesis inhibition. And so here are your bactericidals. Your beta-lactams are listed there, your aminoglycosides, and your fluoroquinones. The bacteriostatic are those on my right side and your right side too. So bacteria antibiotics work in various ways. Pharmacokinetics and pharmacodynamics are very, very important. For example, pharmacokinetics are the time course of antimicrobial concentrations, and I'll elaborate that shortly. Pharmacodynamics are the relationship between antibiotic concentration and effect. So, for example, concentration-dependent antibiotics or aminoglycosides, fluoroquinolones, they maximize concentration. So you want to get that peak concentration. Time-dependent killing antibiotics are your penicillins and cephalosporins. It's the maximum duration of exposure at a given serum level. Okay? So in one instance, you want a really good peak and a low trough to reduce toxicity. On the other instance, these are relatively not toxic. You want a sustained and long term. So in the case of penicillin, this is why you can give it perhaps twice a day on day 1 through 5, But by day 10 to 14, you probably ought to be giving ampicillin, penicillin, Q6 hours because of the excretion of the antibiotic, and you can't maintain that high level. Early onset infection, we still use ampicillin and gentamicin. They probably are still the appropriate drugs to use given the flora and given the pharmacokinetics and given the toxicity. Late onset infection, vancomycin and gentamicin. There's a recent study out because we have been using a anaerobic antibiotic in cases of necrotizing enterocolitis. There's a very new study that's just been published, or at least us had access to, that demonstrates that adding clindamycin or flagyl really doesn't help in the morbidity or the mortality. Gentamicin, as I mentioned, you want peak levels, you want low levels, so you want to keep your serum levels low, less than 1.5, and you want to stop the antibiotic quickly, and I'll be elaborating on that shortly. Peak levels for gentamicin, you can see, for synergy, you don't need as much, and so you use lower doses. Vancomycin, it's not usually nephrotoxic in spite of what many people will say. However, if you're giving an aminoglycoside or you're giving a diuretic such as Lasix, you do enhance toxicity. And lastly, the use of broad-spectrum antibiotics, third-generation cephalosporins and others, is associated with a rapid occurrence of bacterial resistance. So if you really want to grow resistant bacteria, use third-generation cephalosporins. You'll do a superb job at doing so. And you increase your risk of fungal infections, and actually you increase the risk of dying. And limit the use, therefore, with patients with gram-negative meningitis or resistant gram-negative sepsis. Infection prevention, you can see them here. I'm not going to dwell on it. And the most effective methods are hand washing, hand hygiene, and hand washing. If you can keep that, keep it going. Central line bundles, I'm going to skip this. And one point, if you are trying to prove or disprove central line infection with a non-pathogenic bacteria, in other words, Staph epi, you need to have blood cultures from the periphery and central line. You need 2 cultures, therefore, with at least 1 milliliter blood. 1 milliliter blood in current blood culture bottles is extremely important. If it's less than 1 milliliter, you can't necessarily trust the culture results if the culture is negative. Growth of the same organism then in each culture, similar genotypes and antibiotics, growth within 15 hours, invasive catheter in place for greater than 3 days. If you haven't got these criteria, you cannot call it a true catheter infection, even though the definition for catheter infection is different. But for truly, so you can, the point I'm making is you can stop antibiotics a heck of a lot shorter time in this circumstance. Okay. Let's move to the end and somebody flip over the slides to the really important stuff. Okay. All right. Okay. The NICU is a rich environment for doing QI studies. If you were sort of reading between the lines for the first presentation, you can sort of say oh, that's a perfect spot. We can look at that. So I'm going to go through some of this. Estimated expenses for premature babies. They're not cheap. They're not even cheap in terms of central market costs. They're a very expensive proposition, and you can see $78,000, $80,000 per preterm infant at the high end of those costs. So there's a high burden of morbidity and mortality, and a lot of it's caused by us. Antibiotic overuse, formula feeding, H2 blocker use, poor central line catheter care, and a lack of hand washing. So each one of these areas, it's a rich area for developing a very simple and very effective QI project. I'm going to talk about bacterial overgrowth first. There's multiple etiologies for bacterial resistance. It's an acquisition of the enzymes that the bacteria produce that alter antibiotic structure, mutation in bacterial targets such as penicillin binding proteins, and changes in pumps that move the antibiotics from the bacteria or decreased entry sites. The bacteria, as I noted earlier, are very smart. But there are a couple mechanisms for bacterial resistance that are aside from the intrabacterial perspective. One is underdosing. In other words, you're not using the proper antibiotics at the proper dose in order to truly kill the bacterium. And the lack of specificity when you're overreaching your antibiotics. For example, cephalosporin use, as I noted earlier, is associated with increased candidal infection, necrotizing enterocolitis, and mortality. And in fact, there are other causes that are related to the number of organisms. My sister used to be a marine biologist, and she used to count diatoms in San Diego Bay. The more species of diatoms, the less pollution. The more species of bacteria, the less pollution. The less likely you're going to be infected because they're competing with each other for foodstuffs and environment. Translocation of bacteria to the GI tract, secondary changes to intestinal microbiome are very, very common and very well known. And early postnatal as well as early prenatal antibiotic exposure for GBS prophylaxis is going to change this biome. Formula feeding is going to change the biome. Longer courses of antibiotics are going to change the biome. If you use short courses of antibiotics, 1 to 3 days, and have breastfeeding, then in about 2 to 3, maybe 4 weeks, you reconstitute a breast milk biome and decrease the risk of infection for that baby. Greater than 5 days of antibiotics is associated with increased lengths of stay, necrotizing enterocolitis, and death, no matter what the antibiotic used. There's a 7% increase in the odds of developing NEC for each additional day of empiric antibiotics beyond 5 days. So antibiotic stewardship is terribly important. Keep an eye on who is using the antibiotics, what antibiotics are used, and how long they're being used. And you need to, this is something that you need to bird dog with the pharmacy, who's getting antibiotics and who isn't, and make sure that you're doing proper methodology. Okay, this is a graph, an algorithm that you can't read, but it shows a way to approach a late onset infection workup. And this shows that if your symptoms go away, your organism is not recovered, that you stop your antibiotics in 2 days. In fact, gram-negatives will grow frequently within 12 hours, very rarely later than 18 hours. So if you have a negative culture for gram-negs, stop your gram-negative coverage. You can do it with 1 dose. Gram-positive coverage may take another day. Feeding, cesarean section, you're colonized by organisms in the environment. Vaginal section, or vaginal delivery, you're colonized by maternal organisms. Breast milk, as noted, is really, really good, particularly mommy's breast milk. And you have breastfed versus formula fed. And you can tell here the type of feeding and NEC. Even with donor milk, it may not protect against all types of infection and growth, but it certainly does protect against NEC. H2 blockers. H2 blockers cause the microbiome in the stomach to change and increases the risk of ventilator-associated pneumonia and infection because it changes the flora. CLABSI, you need bundles in order to change the incidence, and it will change the incidence. It will get you to the point where you can really improve. And let me show you a study here. This is our central line bundle at Texas Children's, and you can see we've been trying to do lots and lots of stuff, but we've changed our incidence from around 3 to 5 down to 0 to 2. And we think that this is a good thing. All sorts of things that we didn't even know were happening. We found that we had leaking tubing, which caused a spike in our NEC. We found that doing tubing changes during rounds is probably not a good idea. That too many people, too much stirring up of dust and fomite microorganisms. Hand washing, as I noted in the first presentation, if you're going to do one thing, do it well. It's hand washing, and more hand washing, and if your skin doesn't like it, tough. Okay, that got me through finished, but I'm afraid I did not dwell long enough on some really important points. But There are multiple opportunities within the NICU to do very simple QI programs. Watching for hand washing is something with unsuspecting people. Looking at your processes for changing your bundles and your central lines. Are you changing in the middle of rounds because it's during the day, as opposed to, say, putting them off at 6 or 7 o'clock in the evening when there's less traffic? Looking at your antibiotic usage, how not only what's being used, but how long it's being used, will pay real dividends in decreasing the cost and length of stay of our fragile premature babies. Thank you.
Thank you. Excellent. You feel like you ran a race.
I hope so.
Okay, do we have any more questions for either Dr. Speer or Dr. Meyer?
The question is, do I draw cultures immediately or do I wait 6 to 12 hours? I think, and I didn't get to talk about it, there is, for babies greater than 34 weeks gestation, there are the algorithms developed by Kaiser Permanente that allow you to decrease antibiotic use. The problem with them, don't rely totally, because the problem is one of the larger studies showed 5 babies got positive cultures and were asymptomatic at the time of delivery, but had positive cultures. However, if you use the algorithm, you can certainly decrease the antibiotic pressure on organisms and resistance. And so if you have a policy where you're going to do Q 30-minute, then Q 1-hour vital signs, and somebody's really looking at that baby, not mom, but some professional is looking at the baby, and your baby's does no symptoms for 6 hours, you're probably in pretty dang good shape. But I would draw cultures immediately. If you're drawing it properly and the kid's bacteremic, you'd sort of like to know about it. But I think in the asymptomatic, particularly greater than 34-week baby, you can use the Kaiser Permanente algorithm to decrease your exposure to antibiotics immensely. And it's really only for equal to or greater than 34 weeks. It's not been studied less than that. Question is, are Texas hospitals on the path or below the path, like under the bus? They are probably on the path, but they're probably not moving very quickly to get out of the way of the bus. So I think if you tailor your program correctly, you can decrease starting antibiotics. And again, you can decrease the length of time of exposure to antibiotics. It takes some willpower. I would start simple. And I'd probably start on stopping antibiotics in a timely manner and watching what antibiotics are being prescribed, because that's going to probably have the most change on your flora that's in your nursery. And then I would work out a program to utilize the Kaiser Permanente with proper safeguards. The Academy of Pediatrics came out with 3 ways to address this population, the equal to or greater than 34 weeks. They used 3 things. I can't remember the third, but the 2 things that we've adopted is the Kaiser Permanente algorithm and close observation. So we're sort of double dipping there to make it safer. Any other questions? I thank you, the lone neonatology contingent at this overwhelmingly obstetrically oriented conference. Just remind your obstetrical colleagues that the things that they do bad or good impact the degree of prematurity and impact the illness level of the babies that we take care of.
And I think we had one remaining question that Dr. Guillory gave about what can we do about the disparities, how to address that.
You know, yes, I'm happy to do this because there's actually both research and a lot of practical things to address what you're talking about. So in NICU, we actually have a DVD that we made specifically, not necessarily African American, but for populations that were more likely than others to deliver a premature baby, and it's called In Your Hands. It's 20 minutes long, it's English and Spanish, and it's our own families. So I think that is a quick one that is easily used. The second one is, I think that what most institutions I know we have advocated is moving away from the whole idea of milk as feeding. And for example, in this DVD, the physician is shown speaking to the mother and saying, you know, if your baby's born at 26 weeks, these are some of the challenges we expect. Your baby's going to need antibiotics. Your baby's likely to need a blood transfusion. And one of the things we need from you is we need your milk, because your milk